the group. Today, we have very eminent pediatricians from Abuja. Our presenter is Dr. Seyi Oniyangi, and our moderator is Dr. Funke Lawson. I'm very, very happy to welcome both of them to this platform. So without much ado, I will hand over the proceedings of the day to the moderator, Dr. Funke Lawson. And at the end of the meeting, I'll probably say one or two things in closing. So I welcome you all once again. I wish you a very fruitful time. The topic is very, very important, especially to pediatricians in private practice, because we know when children with sickle cell disease have stroke, it's very, very distressing to the parents, very distressing. And it's very dangerous for the child, for the sickle cell patient himself. And, it's confounding for the pediatrician because the parents will usually say, well, we have been coming to your clinic, we have been observing all the do's and don'ts, we have been taking our medications. How come you didn't know that this was going to happen? How come you didn't predict it and warn us about it? But now there is technology, and there's a lot of hope in this regard. So, lectures such as this is very important in order for us to know what to do and to be at the cutting edge of management of these children. So without much ado, I'll hand over to Dr. Funke Lawson. Over to you. Thank you very much, everyone.
Thank you, sir. Thank you, Mr. Chairman. Good afternoon, our esteemed elders, teachers, the chairman, and members of the Guild of Pediatricians in Private Practice, other attendees. I'd like to join the chairman to welcome everyone to this presentation on stroke prevention in sickle cell disease. I thank the organizers for the opportunity given to me to moderate this webinar. This is a topic I'm really passionate about. And many of us in private practice manage children with sickle cell disease. So it's quite relevant to all of us as we will get updated on the guidelines for the prevention of stroke, both primary and secondary stroke in sickle cell disease. We are fortunate to have an expert with us in this area, Dr. Seyi Oniyangi. She's going to speak to us on it. She is a graduate of Ahmadu Bello University, Zaria. She's a fellow of the West African College of Physicians. She presently works as Chief Consultant Pediatrician at the National Hospital, Abuja, and her areas of interest are pediatric nephrology and pediatric hematology. And she set up the clinics for these two. She has participated in several trainings and research in these areas of interest and has several peer-reviewed journals. Both of us belong to various networks and research groups on sickle cell disorder. And I assure you that we are in for an interesting and educative session this afternoon, which will be followed by robust discussion, I believe. And we hope that the knowledge that will be shared during this presentation will also prevent the act of some medical personnel discouraging the parents of these sickle cell children with risk for stroke from following the recommended protocols. So on behalf of the Guild of Private Practitioners, I welcome Dr. Oniyangi to give her presentation. It will be for 30 minutes. And please write down your comments. At the end of 30 minutes, we are going to have 15 minutes of questions and answers. Thank you, Tony Ogi. Over to you, please. Thank you for accepting.
Thank you very much, Funke, for this wonderful introduction. Thank you. Good afternoon, my esteemed elders and the Guild of Pediatricians in Private Practice. I want to thank you very much for the opportunity that is given me to be able to talk about stroke in sickle cell disease. And I will try to talk about this in 30 minutes. And I thank you very much for giving me this opportunity. My name is Seyi Oniyangi, and I look after children that have sickle cell disease. Please, I want to ask, can my screen be seen? Can you see my screen?
Yes, we can.
Okay.
We can see your screen.
Okay, thank you very much. Well, the topic of the presentation is stroke prevention in sickle cell disease. And we'll be talking about children. I'm trying to go to slides, what do you call it? For it to go to the slide mode.
Slideshow.
Slideshow, yes.
Please look at the top. You will see slideshow after animation.
After animation. No.
Just you have insert design. Then just raise your mouse up a little bit.
After animation. Sorry, there's this thing from the Zoom that has come up and covered the area where the slideshow is supposed to be.
So you can go downwards at the bottom.
Okay.
You see there's a place you can, yes, right there.
I've got it. Thank you very much. Okay. So stroke. Children that have had strokes in sickle cell disease are children that we see commonly, because all of us see children that have sickle cell disease in our communities, and we all look after children that have sickle cell disease. So this is just to talk about how to prevent stroke occurring in children that have sickle cell disease as much as is possible. Sir, I'm not sure that it's possible for us to prevent stroke 100% in sickle cell disease, but we will try as much as is possible, because I believe only the Almighty can do that. So the outline of the presentation, it's going to follow this order. We'll talk about the introduction. I'll just talk briefly about what is stroke and how it occurs in sickle cell disease, the consequences of stroke in sickle cell disease, and how the children at risk of stroke in sickle cell disease can be identified, and what to do with these children after having identified them to have a risk of stroke. I'd like to start with a case presentation, which was a child that presented to our facility. It was a 7-year-old male child that presented to the facility with sudden onset of left-sided body weakness, inability to walk, or sorry, this was supposed to be talk, whitening of the hands and soles, and associated deviation of the mouth to one side. He had no history of fall or trauma to the affected side or previous convulsions or loss of consciousness. And he's the first of 2 children. Neither of their genotypes were known then. And salient findings at presentations were those of a pale jaundiced child who had a 7th nerve palsy, was with hypotonia and poor and grade 3/5 power on the left side of the body with hepatosplenomegaly. And unfortunately, the diagnosis that was made in this child was that of a child that had had a stroke in a newly diagnosed patient with sickle cell anemia. And when you look at this case, you will see that this was a 7-year-old child who was newly diagnosed with sickle cell disease after he had had a stroke. So he never gave anyone the opportunity to try to prevent the stroke from happening. So what is a stroke? The cooperative study of sickle cell disease defines stroke as an acute neurological syndrome that is due to occlusion or hemorrhage of cerebral vessels with resultant ischemia and neurologic symptoms, and these must last greater than 24 hours. So when the stroke is overt, there's that sudden onset of focal or global neurologic deficit of vascular origin. And like I said, it lasts greater than 24 hours. When it lasts less than 24 hours and is associated with recovery, it's termed a transient ischemic attack. Now, a silent stroke or a cerebral infarct lacks this global neurologic details, and it's only diagnosed by abnormal imaging on MRI. That's for the silent stroke. But the stroke has occurred, it's just that there are no focal neurologic details that happened. And when we say primary stroke, it means that a child that has never had a stroke before in life. And secondary stroke is when there is repeat or reoccurrence of a stroke in the same child. So as we all know, Nigeria has the largest burden of sickle cell disease, of children with sickle cell disease in the world. And up to 2 to 3% of our live births are affected with sickle cell disease. Now, sickle cell disease is the most common cause of stroke in childhood. And these are both these are majorly ischemic, 75%. But adults with sickle cell disease can also have stroke, and these tend to be hemorrhagic. And the silent strokes also occur in children that have sickle cell disease. In as much as 27 to 37% of the children between their 6th and 14th birthdays, respectively, they have had silent strokes already, which is a very large amount of children. And these are a very, very devastating complication of sickle cell disease. You only have to see one child that has had a stroke and the neurologic sequelae that occurs to remember this for life. It occurs in up to 7.8 to 11% of children with sickle cell disease by the age of 20 years. And it reoccurs in as much as 50% of these children. 50%, 1 out of every 2 children that have had a stroke from sickle cell disease, the stroke may reoccur. Now, the problems that this might bring forth is that the child may die. Or if the child doesn't die from the stroke, there may be lifelong impairments that can occur after the first stroke. And there may be cognitive dysfunction. The child can no longer go to school, for example, assuming the child recovers well enough to be able to have the physical activities. There might be blindness that would occur. There might be deafness. We see aphasia quite commonly. And then there might also be hemiplegia or quadriplegia that we see, convulsions, seizure disorders, and other motor disabilities. So what these strokes do is that it prevents the affected children from attaining their true potential in life. Because once the child has had a stroke and their neurologic sequelae, then it has stolen the true potential from the child in life, and the child is going to be dependent on others. So our children that have sickle cell disease in Nigeria, do we have stroke? Do our children have stroke? What work has been done in Nigeria for us to determine whether our children have stroke or not? And we find that for our children with sickle cell disease in Nigeria, there's a prevalence in Nigeria that has been reported of 3.6 to 8.4% of children that have had stroke. And this is probably an underreporting of the number of children that have had stroke, because these are studies that were based from hospital facilities and not community-based studies. And these children, like I've been said before, these strokes tend to reoccur in these children. and as much as 46.2% will have reoccurrences of stroke without intervention. Now, what is the pathophysiology of stroke? The pathophysiology of stroke in sickle cell disease remains poorly understood because it involves not only the sickle red blood cells, but also the vascular endothelium, inflammation, and coagulopathies. When there is overt stroke, it's mainly related to stenosis and occlusion of large cerebral arteries of the circle of Willis. And these are mainly the intracranial internal carotid arteries, the proximal middle cerebral arteries, and the anterior cerebral arteries. These are large blood vessels that supply the brain. And so when this happens and there is obstruction to the flow of blood on that side, you can imagine the magnitude of the portion of the brain that is going to be affected when the stroke occurs. And like I said before, children have ischemic strokes and adults tend to have hemorrhagic strokes. And this is just to remind us of the circle of Willis that supplies the blood supply to the brain. And the internal, this is the middle cerebral artery. We can see that it is such a large vessel that supplies portions of the brain. And these are the ones that now tend to get obstructed whenever there is a stroke that has happened, as well as the internal carotid artery. So when there's polymerization of the deoxygenated hemoglobin S, which may be the primary event, there would be adherence of sickled red blood cells to the vascular endothelium, leading to stasis and vasoocclusion. Now, this adherence of the sickled red blood cells, they tend to do two things. First of all, it damages the vascular wall, causing intimal hyperplasia of the large vessels. And this will gradually lead to a progressive occlusion of the large cerebral arteries. There will be tissue hypoxia in the portions of the brain that the vessels are supposed to supply with blood, and there could also be superimposed thrombus. In addition, the adherence will set up the process of an inflammatory process, which will affect leukocytes, release cytokines, reactive oxygen species, which will further worsen the inflammation and the stasis and cause further collateral damage that will occur to those areas of the brain. And this is showing this in a simplified diagram. So we can see that there is we can see the sickled red blood cells and the reticulocytes, the white blood cells, they're all adhering to the intimal layer of the blood vessels. And see how large these blood vessels are. In addition, there could also be hemolysis that is occurring, and there would be release of nitric oxide that will get mopped up and lead to further vasoconstriction of these blood vessels. So this together would now lead to the narrowing of the blood vessel. And this narrowing of the blood vessel is what is now going to reduce the amount of blood flow that is going to the brain and cause the tissue hypoxia and the infarction and the ischemia that will subsequently occur. And this is it in another simplified manner. So when the stroke occurs in a child with sickle cell disease, it takes this lovely child, as we can see from here. We can see what has happened here. You can see the area of infarction that is being shown by the MRI, and it takes the child to being wheelchair bound and living with a disability. And it has robbed this child of her potential in life, of her true potential. She now has to learn to live with the disability. And these are other MRIs other MRIs that show these this damage that can occur when a stroke has happened from the sickle cell disease. So with the stroke, there can be developmental delays, cognitive impairments, behavioral problems, physical disability, and seizure disorders. It causes financial and psychological strain on the family and the caregivers. And in addition to that, we have the problems that are associated with blood transfusions in particular, which are used in the management of these children, such as volume overload and transfusion reactions, to mention a few, and infections. So the management of stroke in sickle cell disease, it requires multidisciplinary team approach with multiple specialists. It's expensive, it's very tasking to the specialist, to the child. It's very worrisome to the parents, and it's a very, very devastating thing that occurs when this occurs. And basically, the treatment that we can offer when this has happened is that we want to limit disability and prevent reoccurrence of the stroke, because the stroke has already happened. And once the stroke has happened, it's done. I mean, the stroke has happened. So we need to prevent the very first stroke in sickle cell disease. That is our goal as caregivers of these children, to prevent that first stroke that can cause all these problems. So how do we prevent the stroke, the first stroke in children with sickle cell disease? The first thing we need to do is to be able to identify the child that has sickle cell disease, because we don't want the child coming into us and being diagnosed when the child has had a stroke, which is a scenario that all of us have come across. So this brings to task the mind that we should all know our genotypes, and we should be able to screen as many children as we come in contact with, and many families as we know, to know their genotypes of their children. Then once we have identified the child with sickle cell disease, we can now identify the identification of that child that is at risk of stroke will allow us to institute therapy to prevent the first stroke in sickle cell disease. And in addition, there'll be measures to prevent reoccurrence of stroke in sickle cell disease. So I'll be talking now about preventing the first stroke in sickle cell disease. Now, children at risk of stroke can be identified by abnormalities on transcranial Doppler ultrasound, and preventive therapy can be commenced. When the blood flow velocity that occurs, that is identified by the transcranial Doppler ultrasound, is greater than 200 centimeters per second in the distal internal carotid, middle or anterior cerebral arteries, it shows that that child is definitely at risk of having a stroke from sickle cell disease. And apart from the transcranial Doppler ultrasound, there are other risk factors that have been identified that might tell us that this child, these are risk factors for having stroke in sickle cell disease. The first is the genotype of the child. The children that have sickle cell anemia and sickle cell beta thalassemia are the most prone of the sickle cell disease groups to have stroke. It's not that the other types of sickle cell disease cannot have stroke, but it's just that they are the ones that are most prone to have sickle cell disease. And then the age of the child. When the child is aged 2 years, between 2 years and 16 years, there's also the risk of stroke. When the steady state hemoglobin level is low, it constitutes a risk for the child. It's a risk factor. And when the white blood cell count is elevated, when the reticulocyte count is elevated, acute chest syndrome or nocturnal hypoxemia, then it's also possible. These are all risk factors for stroke in children that have sickle cell disease. But the best way that we can identify the children that have at risk of sickle cell disease, Doppler ultrasound, and we have abnormal.
Sorry, I'm not hearing her. Are we hearing her?
I cannot hear her.
Dr. Oniyangi, seems like she's gone off.
We seem to have lost her temporarily. So let's hope she can join soon. She can rejoin soon.
She's back on.
But she's on, but she's muted.
Okay.
Let me call her.
Yeah.
Okay, she inadvertently muted herself.
Oh, dear.
IT, can you unmute her, please?
I've sent a request to her to unmute.
I sent it to her too, but she doesn't seem to be able to do it. Is there any way you can just unmute her?
Let me call.
Yes, I've seen me. So how do I get back to the slide? Thank you. How do I get back to the slideshow?
You go to share screen.
I found it. Okay. Thank you. Hello, please, can you hear me now?
We can hear you. Welcome back, Dr. Oniyangi.
Thank you very much. And I'm sorry about the break in transmission. I think we're talking about the transcranial Doppler ultrasound waves. Now, these transcranial Doppler ultrasound waves, they're non-invasive. It's a non-invasive, painless method that can assess the blood flow velocity by ultrasound waves to detect areas of increased blood flow in the brain. When there is a narrowing in the blood when there's a narrowing in the diameter of the blood vessel, this leads to an increase in the pressure and the flow rate of the blood that passes through that vessel. And this increase in the flow rates can be identified by the ultrasound waves. And it's able to detect areas of increased blood flow that occur in the brain. Now, these higher velocities, the flow rate is measured in terms of velocities as in centimeters per second. That's how we measure the velocity of the blood flow that occurs. So when we have a higher velocity in any of these vessels, it is usually associated, like I said, with a decreased vessel diameter and can be used as a surrogate marker for intracranial vasculopathy. When the velocity of the blood flow through a narrowed vessel in the brain is higher than we expect it to be normally, then that tells us that there's a narrowing in that blood vessel. And that narrowing is what is now putting the areas distal to it at risk, because there would be inadequate blood flow that is going at high pressures and inadequate oxygenation that would occur. And this creates the ischemia that now occurs and leads to the ischemic process that occurs. So the transcranial Doppler, the ultrasound waves are able to detect these areas that have the increased blood flow in the brain. So once we can identify these children that have increased blood flow in the blood vessels going to the brain, we are able to identify that these children are at risk of having stroke. And therefore, we can now commence prevention strategies to prevent the stroke from occurring. So the stroke can be prevented by the use of transcranial Doppler ultrasonography to identify those who are at risk of having stroke and commence prevention strategies for the children. And what is the evidence to support this? This slide is quite important. It's the slide from the initial study that was done by Adams et al. In 1998, in which they identified children and looked at the time in months, looking at the time in months on the x-axis, as well as the probability of the child remaining stroke-free on the y-axis. And what they found was that for children whose the blood flow velocity was less than 170 centimeters per second, the probability that they will remain stroke-free at 35 months was very high, of 1. But for children whose blood flow velocities were between 170 to 199, probability had begun to reduce. And for children who had blood flow velocities greater than 200 centimeters per second, you can see how it reduces all the way until by 35 months is less than 0.5 or 50%. So this shows that the stroke risk increases with the blood flow velocity rate, which we can identify by using the transcranial Doppler ultrasound to identify these children and the risk. So the blood flow velocity, when there's an abnormal, like I said, when there's an abnormal blood flow velocity, it predicts the stroke risk in the children. When the blood flow velocity is less than 170 centimeters per second, this is a normal stroke risk, and it's only about 2% chance that the child is going to have a stroke. Or when the blood flow velocity is 171 to 199 centimeters per second, or in the conditional range, as we say, the risk has increased to 7%. When it is greater than 200 centimeters per second, this is grossly abnormal, And the risk is there. The predictive risk is that 40% of these children, they're going to have stroke. So this is strongly associated with an increased stroke risk that occurs in the children. So the transcranial Dopplers are the only screening methods to prevent stroke in sickle cell disease. And accurate, and it's reproducible to select most patients that are at risk of overt stroke. And it's recommended by the Nigeria Guidelines for the Control and Care of Sickle Cell Disease, as well as the United States National Heart, Lung, and Blood Institute, to be able to screen children and to be able to prevent stroke in sickle cell disease. So let us look at the interpretation of what we have when we carry out our TCD screenings, and what are the outcomes that we expect to have. When the blood flow velocity is less than 70 centimeters per second, this is the maximum cerebral blood flow velocity. And what is usually chosen is the higher of the two, because there are two blood vessels. The middle cerebral artery, for example, has a left and a right one. So when we're trying to assess the risk for stroke, we choose the higher value. Could be the left, it could be the right. So when it is very low, when it is between 70 to 169, the interpretation is a normal risk. When it is 170 to 184 centimeters per second, it's low conditional. 185 to 199 centimeters per second, it's high conditional. When it is 200 and above, like I said, centimeters per second, it is abnormal. And this suggests that there's an imminent stroke risk and the need to commence preventive therapies immediately or as soon as possible. Now, I should have mentioned earlier that there are two types of transcranial Doppler ultrasound screenings that we do. The conventional one is done using the non-imaging technique, which is the technique that was used by the original study that I shared with you. While the other one is the imaging technique, and there are just subtle differences in the two of them. But the imaging technique tends to give values that are about 10 to 15% lower than the values that we get from the non-imaging technique, such that instead of having 169 as the normal, 169 centimeters per second as the normal cerebral blood flow velocity, for example, that would be reduced to 155 centimeters per second. And so that it would now depend on the technique that was used. But either way, the transcranial Doppler screening is the transcranial Doppler ultrasound is the screening method for identifying children who are at risk for stroke. Now, there are certain limitations of transcranial Doppler screening. The first is that in our environment, it's not widely available. It's not, even where it's available, it's not widely accessible, nor is it affordable in all of our environments. In addition to that, it is highly operator dependent. The person who is doing the transcranial Doppler has to be trained on the use of the machine, the interpretation of the machine, and on how to ensure that we get the best readings. And the measurements of the velocities may be affected by other factors, such as the gender, the hematocrit value, or the thickness of the skull bones. And the TCD measurements may actually change over time. Because if we have a normal reading and we repeat it in another year, may have changed over time to become a conditional reading. And the other thing is that the transcranial Doppler screening does not affect the silent cerebral infarcts that occur. So how do we screen for these silent cerebral infarcts? We need to do brain imaging, which are the MRI or MRA, magnetic resonance imaging or magnetic resonance angiography of the brain. And these are usually done when we have features that might suggest, for example, a child has been doing well in school and is no longer doing well in school, has this kind of features that will suggest that we need to do screening, because we cannot do MRI and MRA or MRA routinely in our children, the same way that we do with transcranial Dopplers. And the other thing is that children that have low transcranial Doppler results, these children might also be at risk of stroke. And they may need to be further screened, because so the children that have low TCDs as well may need to have further screening or further brain imaging. So are there any other ways that we can use to predict stroke in sickle cell disease? I'd like us to have a discussion on that. And are there any differences in stroke risk as regards to the genetic differences that we have in the types of sickle cell disease that we have available? Now, what is the basis for preventing the strokes? We can have our stroke prevention measures, and these stroke prevention measures are associated with a decrease in the risk of stroke in sickle cell disease by as much as 90%. These are when we do the chronic blood transfusion therapies or exchange blood transfusion therapies. They keep these have been found from randomized controlled trials that have been done to reduce the risk of a child having a stroke, a child with an abnormal transcranial Doppler ultrasound result, having a stroke from sickle cell disease by as much as 90%, which is really a lot. Then we also have the drug hydroxyurea, which has been found to reverse abnormal transcranial Doppler results back towards normal, and therefore decreasing the risk of stroke. And we have bone marrow transplantation. So these are some of the primary stroke preventive measures that are available. So the evidence for the chronic blood transfusions, as we all recollect the stroke prevention trial in sickle cell disease, in which children that were identified with abnormal transcranial Dopplers were randomized to receive either chronic blood transfusion or not. And it was found that this was how the children that were in the trial arm that had the chronic blood transfusions had the 90% reduction in stroke risk. And so the trial actually had to be prematurely stopped because it was obvious that the children were doing better when they had the chronic blood transfusions. But for how long will these chronic blood transfusions go on? And therefore, there was another clinical trial that was done, which was the STOP2 trial, in which it was looked at to see whether the blood transfusions could be stopped after 2 years in children that were already getting the blood transfusions to prevent stroke, because of the high risk of side effects that were occurring from the blood transfusions. And what was found was that, no, we couldn't stop the blood transfusions, but rather one should continue the blood transfusions and look for ways in which we can prevent iron overload in these children and other conditions. And this was followed by the TCD with transfusions, abnormal TCDs that have been on transfusions, and then they were changed to hydroxyurea therapy. And it was found here that the children that had received blood transfusions for up to a year before being changed to hydroxyurea therapy, the results, the hydroxyurea was not inferior to blood transfusion therapy for primary stroke prevention in these children that had elevated transcranial Doppler measurements. So this brings to view the challenges for primary stroke prevention in children with sickle cell anemia in our climes. as we have found, the screening method that we should use is the transcranial Doppler ultrasound for screening to identify the child who is at risk for stroke in sickle cell disease. And apart from that, and after that, chronic blood transfusions. But however, what was found in studies that were done were that the high economic cost of blood transfusion, there was unavailability of blood, there were cultural beliefs and high frequency of transfusion reactions. Therefore, there was 0% was what was reported by Lagunju et al. Of children that would accept to have blood of caregivers that would accept for their children to have chronic blood transfusion for primary stroke prevention. Because of all of these problems that I had mentioned. And this therefore brings the need to identify an alternative to blood transfusion therapy, because we cannot carry out these monthly blood transfusion therapies here. And then apart from that, to train and equip the healthcare team to implement the intervention and to have support for healthcare provision in our clients. So this brings us to the drug hydroxyurea. Hydroxyurea is an anti-metabolite that is used in sickle cell disease, and it's very beneficial in improving the course of the disease. In fact, it has become a disease-modifying agent and a standard of care for children with sickle cell disease in the more developed climes of the world, and fortunately in our own areas as well. It increases the concentration of hemoglobin F in the red blood cells, and therefore it acts as an anti-sickling agent. And it's been found to reverse abnormal transcranial Doppler studies back towards normal, therefore decreasing the risk of stroke. So the dosage of the drug can be given it's usually given as a single daily dose, 10 milligrams per kg, increasing to a maximum of 30 milligrams per kg. That's when there's a fixed dose schedule, or up to a maximum tolerated dose. The maximum tolerated dose is the dose at which we begin to see the side effects of the drug, and we're able to achieve what we want to achieve. But this remains underutilized for our sickle cell disease standard of care in our environment here. That's the drug hydroxyurea. And there were 2 trials that were carried out in Nigeria here. The first was carried out in Kano, the SPIN trial, which looked at fixed moderate dose hydroxyurea therapy of 20 milligrams per kilogram body weight per day as primary stroke prevention in children with sickle cell anemia, and compared this to standard therapy in the children. And what was found from this trial was that the children that had the moderate dose hydroxyurea therapy had reduction in the transcranial Doppler ultrasound studies. In their TCD results, there was reduction, which showed that the risk for stroke was reduced in these children. And therefore, had showed that hydroxyurea can be used for primary stroke prevention in children with elevated transcranial Doppler measurements. And there was another another trial that was now carried out to look at that compared the moderate dose hydroxyurea therapy with of 20 milligrams per kg per day with low dose hydroxyurea therapy in different sites in Nigeria as well, Kano, Kaduna, and other sites. And what this found was that there was no difference in the incidence of stroke when we gave 20 milligrams per kg per day of hydroxyurea therapy and to 10 milligrams per kilogram body weight per day. Although there were more admissions for the children that were on low dose hydroxyurea therapy, but they did not have strokes in these children. So therefore, what these trials are showing us is that hydroxyurea therapy can be used for primary prevention of strokes in Nigerian children with sickle cell disease, both the SPIN and the SPRING trials. So hydroxyurea therapy, it's, like I said, is a standard of care that's for all children with sickle cell disease where feasible because it ameliorates the clinical severity. However, the costs still remains a problem, especially with the increase in cost generally in the country, the availability of the drug, and then our compliance, the drug adherence with the children, and monitoring of the use of the drug are potential barriers to the use of hydroxyurea in children. But we know that long-term use of hydroxyurea is safe, including in babies. However, we need to monitor the hemoglobin F% when we're giving the children hydroxyurea. And for the side effects, we need to always monitor the full blood counts. We're looking at the hemoglobin levels, the absolute neutrophil counts, which may be decreased, the platelet counts, the kidney and the liver functions. And in addition to that, we now have locally produced hydroxyurea. So hydroxyurea therapy, since we are unable to carry out chronic blood transfusion for children as primary prevention of stroke, we can give our children hydroxyurea to prevent stroke from occurring in these children. And the hydroxyurea therapy has been found to be effective. So if the hydroxyurea...
Thank you very much. Please, can you round up? You've done almost an hour.
Are you serious?
I think,
so if the hydroxyurea therapy does not work, then we need to consider other options, such as bone marrow transplantation. And so treatment, like I said, the treatment is available. So for the prevention of stroke reoccurrences, I'll just briefly go through it. We have to do chronic blood transfusions as well. And we should also consider hydroxyurea therapy. And also bone marrow transplantation. There's now gene therapy, and we may need to do surgery, for example, revascularization of blood vessels in the brain. Always remember that we need to monitor the MRI and MRA and limit disability in these children. So in conclusion, the stroke is a major devastating complication of sickle cell disease in children and leads to significant morbidity. When the brain damage occurs, it's irreversible. Thus, prevention of the first stroke in sickle cell disease is what we need to do. And transcranial Dopplers are the only screening methods that will prevent stroke in sickle cell disease because it identifies the child who is at risk of having a stroke in sickle cell disease from the abnormal transcranial Doppler results. So we can offer the child primary prevention, which has been shown to remarkably decrease the risk of stroke in children. And these interventions are chronic transfusion therapy and hydroxyurea. And I'm suggesting that we should always do transcranial Doppler studies, and hydroxyurea should be the standard of care here in Nigeria. Thank you very much. I'll stop here.
Wow, thank you so much. Thank you very much, Dr. Oniyangi. I promised you that it was going to be educative and interesting. And I can see almost 100 of us here. Nobody has left. I'm sorry we had to tell you to quickly round up. But definitely we have benefited immensely from this presentation, telling us how to identify stroke, how to prevent it, and the fact that we need to diagnose sickle cell disease early enough before they present with stroke. And then the other types of stroke, the silent stroke, and Nigeria, where we are, and also the types of non-imaging and imaging transcranial Doppler that we have. We've gone through the pathophysiology and so many other things. Fortunately, this is available on YouTube, and many of us who didn't join early, or those who want to listen to it again, can go on the YouTube and we'll be able to get the information they need. It has been so interesting. Thank you very much, Dr. Oniyangi. Really appreciate you. And I believe we all have taken home the points that she has marshaled here. And we're now ready for questions and answers. I think we'll have only like 10 minutes because our time is fast spent. So please, if you can raise your hands, I'll call you, and please go to the point. Welcome, Professor Grinch. I can see you there. I didn't see you earlier. Welcome. Yes.
Thank
So
you.
Dr. Ireta Kafo, you are first. Please, Dr. Oniyangi, note the questions and you'll answer at the end of it all. Please, thank you. So Dr. Ireta first.
Okay, thank you so much, Seyi. There are some concerns about renal function and the use of hydroxyurea. In fact, some people believe it improves renal function. Others believe that maybe it causes worsening of renal function. So at times you may have a child, with microalbuminuria who had been on hydroxyurea. What do you do at that point? Do you stop or you continue? Over.
Thank you very much. She's noted your question. Can we have Dr. Nurezedi? You can also write on the chat box if you have any questions.
Thank you very much. Thank you very much, the presenter, for that beautiful presentation. I have a little question, and it stems from my experience in my own center. I'm a consultant pediatrician in my youth. And last year, we had a Jehovah's Witness child with a TCD value of greater than 200 centimeters per, well, I can't remember the value, the velocity value. So my question is that in a child that has this very high value, obviously can't take exchange blood transfusion because the mother vehemently refused, what do we do? Because hydroxyurea, from my own experience, takes a while. In the literature, it takes about a month for it to start working. So what do we do in that situation, please? In a child that is a Jehovah's Witness. Thank you very much. Hello?
Thank you, Prof. Please. Are you there?
Yes, I am.
Professor Mutai.
Okay, thank you very much. Thank you very much, Dr. Oniyangi, for this presentation. I think I joined primarily because Kano, my center here, was part of the spring trial in Nigeria, and there was no doubt about it that hydroxyurea modifies sickle cell in so many ways that one even shudders at why we are so resistant to allow it to function or to allow it to be standard therapy. The second point is hydroxyurea has been or is in production in Oyo by Bond Pharmaceutical for at least the last 15 to 20 years. I recall participating in a Sickle Cell Foundation workshop on hydroxyurea at least 15 years ago, where it was unbundled, and the cost of hydroxyurea produced in Oyo is just a fraction of what the imported one from Korea, from India costs. Even at this spring trial in Kano, the PI, that's Dr. Michael Gibbon, emphasized that you don't need to, in Nigeria or neighboring countries, go to India or anywhere to buy hydroxyurea. You get it there in Oyo. And he said in one of his papers that I read recently, when he was invited to Ghana, he insisted the Ghanaian Pediatric Society buy the hydroxyurea from Nigeria. But they want to buy from these novelties at almost 5 times the cost. So let us spread this news that hydroxyurea is not that expensive because it is produced in Nigeria. And Michael Gibbon has taken the hydroxyurea produced in Nigeria to the United States at its own cost and had it analyzed in so many labs in the US. And all of them confirmed it was 98, 99% pure and effective. So I'm just using this forum to inform us that hydroxyurea is there in our neighborhood. We don't need to ask our patients to buy Novartis-made hydroxyurea. Thank you very much.
Thank you very much, sir. I have one or two questions before I bring up the questions on the chat. Like I said in the introduction, there are a lot of our own doctors that discourage these patients from taking hydroxyurea, and I don't know why. There are many of them with comments on hydroxyurea, and by the time they go somewhere else, they say, oh no, you don't need to have it, especially those who have done their TCDs, and you have counseled them, and they've used it, and after a while, they say, oh, but you haven't had stroke, you don't need to take it anymore. I think we all need to be on the same page on this hydroxyurea use. For the one who had greater than 200 centimeters per second of velocity from the TCD and is refusing transfusion, of course, we're starting the hydroxyurea immediately. It may take a while to work, but it's been shown that it's very, very effective as well. Then the other thing that we tend to have problems with our policies and maybe registration with the HMOs and acceptability of these management guidelines. Because I know some of our patients who are clients of these HMOs, once they say they are sickle cell patients, they will not accept them. And when they even accept them and you have to do monthly blood transfusion, place them on hydroxyurea, they'll tell you that it's not covered. So there are some other things we need to address in that way. And there's been a line of thought, I don't know how true it is, that proteinuria can occur before stroke, and that if we check the protein in these children, it can also help us to predict stroke because of the low pH, oxygen tension, and higher osmolality in the kidneys. So those are some of my own questions. But I would want you to respond before I go to the chat, because there are a few of them there. Dr. Chuksokoli, we'll take you later, please. Dr.
Okay, thank you very much.
Oniyangi, please, can you respond?
Yes. Thank you very much for the comments and for the information. Thank you very much, sir, Professor Marta, for the information about the hydroxyurea and the fact that it's available in Nigeria. And it is such an effective drug that has been in use for such a long time. In fact, one of our hydroxyurea babies, well, one of the children that we started on hydroxyurea, when we first started using the drug, she recently had a baby about a year ago. She's grown up now, and that is our own local. She's in her 20s now, and that is our own local experience. Whereas the rest of the world had been using hydroxyurea for much longer than before we started using hydroxyurea here. So please, colleagues, like Dr. Lawson has said, hydroxyurea is safe. It's safe. There have been studies that have looked at the side effects of this drug, and they have found that these side effects have, when we weigh the risks against the benefits of using the drug, the benefits of using this drug outweighs the risk from the side effects. And of course, the monitoring is there. If we have any side effects that are going to be detrimental to the health of the child, then the physician would know what to do regarding the hydroxyurea therapy, whether to stop it briefly for some time, like a holiday period, to allow the particular organ to recover, and then continue the child on the hydroxyurea therapy. But the hydroxyurea is the standard of care for children that have sickle cell disease. And in fact, that is what our guidelines of care say, that we should put our children on hydroxyurea therapy because it is so beneficial in sickle cell disease, like Prof has said. Funke, thank you. You have answered the question about the Jehovah Witness. Well, the child has to go on hydroxyurea therapy starting that same day. Is what I will do, because we don't have any other option here. And such a child is unlikely to accept bone marrow transplantation. The child, since they are Jehovah Witnesses. So such a child should go immediately on hydroxyurea therapy. And yes, you are quite correct, doctor. It takes time for the hydroxyurea to start to work. But it's better, like Funke has said, than not giving the child any stroke preventive measures. Ma, about the renal functions and hydroxyurea therapy. Hydroxyurea therapy can improve renal function when it is used. But at the same time, microalbuminuria can be a side effect from the hydroxyurea therapy. So what do we do? Do we stop or do we continue the hydroxyurea therapy in these children? Is a question that you have asked, Ma. And I think it would depend. If the microalbuminuria was present initially before we started hydroxyurea therapy, then one would want to go ahead and continue to monitor and see whether this is going to disappear or this is going to remain. And if it does not remain, then I would actually be quite hesitant to stop the hydroxyurea therapy in a child that has a risk of stroke when I do not have anything else to offer the child. But I would monitor very closely. I might need to take the child off the drug for some brief periods and put the child back on if the renal function deteriorates. But if the renal function does not deteriorate and we're able to monitor this child closely, then I would leave the child on the hydroxyurea therapy, ma'am. Those are the things that I would want to do. And for the HMOs, thank you very much for your comments about the support that we need for care of sickle cell disease in general in Nigeria. We need a lot of support. Sickle cell disease care is expensive. It's very expensive. It's expensive both for the family as well as for the physicians, for the healthcare providers looking after the people that have sickle cell disease. And support from all forms of support are required for people that have sickle cell disease. I hope I've been able to answer the questions.
Yeah, thank you very much, Doug. We have a few comments. One is talking about, hydroxyurea is a game changer. And of course, the challenge is that they come in capsules and there are no lower formulations. It's not below 100 milligrams. So for the younger ones, it is a challenge. Of course, abroad, they have the suspension now, but it's so expensive. So what most people do is just to compound them. The pharmacies compound weekly or every 2 weeks for them. I believe, Dr. Oniyangi, that's what you do too for the young ones.
That's exactly what we do. We compound the drugs. Yes.
Yes, since they cannot swallow. Yes. Then I have a question. Another challenge is that during the TCD in the older parents, older patients greater than 10 years cannot delineate the relevant cerebral blood vessels because of their higher skull thickness. So that's I can't see it well. That seems to be. I don't know whether this is a great general limitation or is operator dependent. That's the question.
Thank you, Ma. If I could just address that. I think that, yes, I agree that the older children have thicker skull bones, and that might make the TCDs a bit technically difficult. But I think that with operator experience, they can do the transcranial Dopplers on these children 10 years, up till 16 years. As long as the skull bones permit the operator to be able to access the cerebral blood vessels, then the TCDs can be done. So it's not that when children are 10 years and above, we shouldn't send them for TCDs. No, because they're still at risk of stroke. So we should send them for the TCDs, and the TCD, the operator will be able to identify the cerebral vessels. Sometimes they are unable to do so. And that in itself, sometimes when they do the TCDs, we get results that say that middle cerebral artery on the left side was not visualized. And that in itself might be a risk for stroke, because it could be that there is so much stenosis on that side of the blood vessel already. So please, I think we should send the children for the TCDs.
Thank you very much. I think sometimes that window closes early. I have had some training in TCD, and sometimes you just can't go through that window. You cannot see the vessels. But if you're able to see one side, like she said, the other side, there could be a problem. That's why you are not able to detect the blood flow there to measure the velocity. But there's somebody asking if there's a maximum age. What is? Sorry, I'm just trying to see this. I'm not, it's just going off. I don't know if anybody else is seeing this. It's going off on my screen. Okay, there's somebody asking that in my facility, we offer chronic transfusion, exchange blood transfusion, and also hydroxyurea is readily available. So if you are seeing a child for the first time with TCD greater than 200, what is the first line you recommend to choose out of all these modalities? So there's a first timer with, okay, it's not a first timer. A patient presents with TCD greater than 200. Of course, high risk for stroke. What is the first line?
The first line treatment for the child with a TCD greater than 200 is an exchange blood transfusion. After we have verified that that TCD is actually correct and is greater than 200. Because the risk of imminent stroke is there. So the first thing to do is to repeat the transcranial Doppler and be sure that the transcranial Doppler is actually abnormal. And if it is abnormal, then we should offer the child the benefits of having an exchange blood transfusion. However, when that is not feasible, then we should immediately start the child on hydroxyurea therapy. And if they are like the Jehovah's Witness that will not do the hydroxyurea, then that will not do the Jehovah's Witness, then they will do the hydroxyurea therapy. But especially if the child has symptoms, we should go ahead and carry out an exchange blood transfusion on that child first, and then continue with hydroxyurea therapy. That's my suggestion.
There's another question about Jehovah's Witness again, with raised TCD, that's the velocity, I guess, and was given omega-3, which worsened the outcome, and that it was observed from literature that the DHA component of the omega-3 actually increases neutrophil activity and worsened the TCD value. Have you read anything about it?
No, ma'am, I haven't read that up yet, but I will definitely read it up now that this has been mentioned. But perhaps somebody else that might have read about that might want to share this with us.
Is there anybody that have read about that? Okay, nobody's putting up their hands. We'll try and take just 2 more questions, but there's... Yes, ma'am.
I don't know.
That's Dr. Chisom.
I was the one that, yes, I was the one that posted that. There are at least 2 literatures right now. I'm actually writing it up for the case report. We quoted 2 literatures that reported on that. Increased neutrophil activity, DHA component. The ideal omega-3 for sickle cell patients should be the one with the eicosahexaenoic acid. But the ones we saw down here, because I have to go to all the pharmacies around me, they have 2 of them, the DHA and the eicosah component. Meanwhile, what we need in the sickle cell is just that eicosahexaenoic component and not the DHA, which increases the neutrophil activity. Again, everything was gotten from the literature, and I was really amazed. But all this while I was thinking that omega-3 was good for sickle cell, but when I realized that, I stopped that child from taking omega-3, the particular child in question, the Jehovah's Witness child. And when that child stopped taking that omega-3, TCD crashed down to normal values. And that gave us an insight into not using omega-3 anymore for any of our patients. So
thank you, Doc, for the information.
Thank you very
Somebody
much.
is telling us is that Lagos State can enact a law on the Child Rights or something, Child Rights Act, so that they can receive their medications. I think one thing that has come up here is whether hydroxyurea is for everybody or not. Can you just address that as the last question? Because we've spent a lot of time, and whether we should put all sickle cell patients on hydroxyurea. It's available, readily available, and it's not too expensive. Bond Pharmaceuticals supply it. Dr. Oniyangi.
Yes, that is the standard of care is that all children, when they are diagnosed with sickle cell disease, should be started on hydroxyurea therapy as a disease-modifying agent. However, we need to exercise caution to be sure that we are able to monitor the effects of the drug and that us healthcare professionals are trained in the use of the drug so that we can look after the children better. Prior to this, we used to say that only children that had severe forms of sickle cell disease should be placed on hydroxyurea, like recurrent crises needing recurrent blood transfusions. But the argument is that why do you want to wait for the child to have these recurrent crises or recurrent blood transfusions before putting them on hydroxyurea, when the drug hydroxyurea can actually prevent these complications of sickle cell disease from occurring? So like I said, the standard of care really is that all children, once diagnosed with sickle cell disease, and in fact, as early as 9 months of age has been shown, should be started on hydroxyurea therapy if we can control all the factors that are required to go along with long-term hydroxyurea use. Thank you.
Thank you very much, Dr. Oniyangi. I think we should give our virtual claps again. Thank you so much. That has been so interesting. And I believe we can go back and listen all over again. I'll now hand over to Dr. Mobolaji Lawal to conclude today. Thank you for being such wonderful audience and for all your contributions. It's been wonderful. Thank you.
So thank you very much, Dr. Lawson, for very ably moderating the session. We have had another very, very rewarding afternoon. And I want to thank especially our presenter, Dr. Seyi Oniyangi, for an excellent presentation, very, very clearly given. Thank you very much. We are very, very, we are better educated now. And, you know, our knowledge and practices on this subject has been further enhanced by this meeting. I want to also thank everyone who has participated and asked questions and contributed contributions to the meeting. I see quite a good number of senior pediatricians. I acknowledge everyone, in particular Professor Grange. Acknowledge Yuma. Good afternoon. So I thank everyone for patiently bearing with us. We normally meet 3 o'clock and we try to finish by 4 o'clock. But as often is the case, we extend a little bit to more than 4 o'clock. We are usually very punctual. And I must observe that recently we have been having full house at our meetings. And this is very, very encouraging. It speaks to the careful choice of topics by the organizing committee led by Dr. Elitu, who is unavoidably absent today. So I want to thank them as well for steering the course of these meetings, and the response has been very, very encouraging. So thank you, everyone, and good afternoon.
Thank you.
Thank you.
Thank you. Bye-bye.